Hello, my name is Dr. Dewan S. Raja. Today I will discuss about pathological changes in the pancreas in type 2 diabetes. Type 2 diabetes is a condition characterized by insulin resistance and relative insulin deficiency. Insulin resistance in the peripheral tissues like that of the skeletal muscles, and there will be relative insulin deficiency from the islet cells of the pancreas, particularly from the beta cells of the islets of Langerhans. Here are some key pathological changes observed in the pancreas of a type 2 diabetic patient. An abnormal incretin effect leading to reduced secretion of GIP and GLP-1 hormones that promote insulin release. Islet cell dysfunction. Islet cells in the pancreas, particularly beta cells, responsible for producing insulin, can become dysfunctional due to chronic hyperglycemia and fatty acids. Excess free fatty acids that compromise beta cell function and attenuate insulin release. Beta cell mass reduction. Type 2 diabetes is associated with progressive reduction in beta cell mass. This reduction can result from various factors including apoptosis or programmed cell death, dedifferentiation, loss of specialized function, and impaired proliferation of beta cells. Amyloid deposits. In some cases of type 2 diabetes, there may be deposition of amyloid protein within the pancreatic islets. These amyloid deposits primarily consist of amylin, a peptide co-secreted with insulin by beta cells. Amyloid deposition can impair beta cell function and contribute to their loss. Fibrosis. Chronic inflammation and metabolic stress in the pancreas can lead to fibrosis, characterized by excessive accumulation of extracellular matrix components such as collagen. Fibrosis can disrupt normal pancreatic architecture and impair islet function. Inflammation. Low-grade inflammation within the pancreatic tissue is commonly observed in type 2 diabetes. Infiltration of immune cells such as macrophages and T cells into the pancreatic islets can contribute to beta cell dysfunction and insulin resistance. Vascular changes. Diabetes can cause alteration in the pancreatic microvasculature, including endothelial dysfunction, capillary basement membrane thickening, and reduced blood flow. These vascular changes can further compromise pancreatic function and exacerbate tissue damage. Exocrine dysfunction. While type 2 diabetes primarily affects the endocrine function of the pancreas, insulin production by the beta cells of the islets of Langerhans, it can also impact exocrine pancreatic function. Chronic hyperglycemia and metabolic abnormalities may lead to exocrine pancreas insufficiency, resulting in impaired digestion and nutrient absorption. So this is an image taken from Robbins-Cotton, Pathologic Basis of Disease, 10th edition. Okay, in obesity, these are the adipose cell, fat cell. This is the fat, this is the nucleus, these are the vasculature. And we must remember that adipose tissue also works as an endocrine organ. Okay, so we have from the adipose tissue, we'll have secretion of adipokine. They are similar to cytokines. They have inflammatory function, immune function, good cardiovascular function, as well as appetite function. Okay, these are released from the adipose tissue, adipokines, free fatty acids. Okay, and this adipokine is associated also with inflammation. So there will be all thing happen here. There will be insulin resistance. Insulin resistance taking place at the peripheral tissue like that of the skeletal muscle. Then what happened? Pancreatic islet cell, beta cells, insulin secretion by beta cell. This is normal. Beta cell secretes insulin that regulate blood glucose, and this is normal function. In case of increased insulin resistance at the receptor level of the skeletal muscle, what will happen initially? There will be compensation by the beta cells of the islets of Langerhans by increased number of the beta cell function, beta cell formation, or enlargement of the beta cell. But eventually there will be decreased beta cell, decreased function of the beta cell, decreased secretion in diabetes mellitus. So insulin resistance associated with obesity is induced by adipokine, free fatty acids, and chronic inflammation in adipose tissue. Okay. Pancreatic beta cell compensate for insulin resistance by hypersecretion of insulin like this. However, at some point, beta cell compensation is followed by beta cell failure like this, and diabetes ensues. So there will be association of obesity, and there is insulin resistance associated with obesity is induced by adipokine, free fatty acid, and chronic inflammation in adipose tissue. Plus, we have also tissue insulin receptor resistance at the peripheral tissue like that of the skeletal muscle. So what happened? Insulin resistance predates the development of hyperglycemia and usually accompanied by compensatory beta cell hyperfunction and hyperinsulinemia in the early stages of evolution of type 2 diabetes. Over time, inability of beta cell to adapt increasing secretory need for maintaining an euglycemic, that means normal blood glucose level state, result in chronic hyperglycemia and the resulting long-standing complication of diabetes. Overall, the pathological changes in the pancreas of a type 2 diabetic patient reflect the complex interplay of metabolic abnormalities, inflammation, and cellular dysfunction. These changes contribute to the progressive nature of the disease and its complications. There is no islet autoantibodies in case of type 2 diabetes. And that's all about the today's topic regarding the insulin resistance, functions of adipokine, fatty acids, and that's all. If you have any question, please feel free to ask me, and please share the information with your friends regarding the pathological changes in the pancreas. Please support my channel. Please subscribe me. Have a nice, wonderful, and blessed day. Bye now.